for other participants to join in. I'd like to check with Nana if you are joining with anyone today from Manzini Government Hospital. Hello, Nana. Are you joining with anyone from Manzini? Nana, can you hear us? Are you joining with anyone from the Manzini Government Hospital team? Hi, Nana. Hello. Nana, can you hear us?
Yeah, I don't get. Hello? Do you get it as now? Do you hear us? Hello? Hello, Nana, do you get us? Hello, do you get us, guys? Do you hear? Alina?
Yes, Mr. Santi.
Are we audible on your side?
Yes, I can hear you.
Okay. Did you hear Messi?
Sorry?
Did you hear Messi when she was speaking?
Yes.
Okay. I think the problem might be with our participant now. Okay, Nana?
Yeah.
Okay, sister, how are you?
Hey, finally.
Okay,
Yeah,
thank
it's my,
you.
yes, I had to climb a tree. So I'm okay
Okay.
now.
We hope you
Yeah.
hold tight there.
Yeah.
Okay, thank you. All right. I think Messi can continue so that anyone who don't hear us, please let us know.
I hope the Manzini team can hear us, but if you have trouble hearing us or communicating with us, kindly use the chat box. Kindly use the chat box so that we can try and sort that issue out. So welcome colleagues to today's session. Thank you for joining us once again. We understand that everyone is busy, but thank you for setting this time so that you can be able to join us for today's session. So we are continuing with our series of pain. We've been discussing pain for the past 2 sessions. My name is Mercy Shabangu. I'll be the facilitator for today's session. I would like my team to kindly introduce themselves before we can continue.
Good afternoon, colleagues. My name is Gomez Melani. Good afternoon, thank you.
Good afternoon, colleagues. My name is Eswatini, Hospice at home.
Good afternoon, colleagues. My name is Paz Moya. I'm also here at Hospice at home.
Afternoon, colleagues. Samuel Lukele, Hospice at home.
Thank you, colleagues. Sister, can you kindly unmute yourself and introduce yourself? Sister Felicity.
Good day, colleagues. My name is Sister Felicity Lukele. I'm working at Mbabane Government Hospital Palliative Care Unit.
Thank you for joining us, sister. Nana, can you kindly unmute yourself and introduce yourself and your team members? Nana? Okay, in the interest of time, colleagues, can we continue? Please introduce yourselves through the chat box, Nana, where you are joining from and the team members that you are joining with. We are quickly going to look at what we spoke about in our last session because we are behind time. We were looking at pain, where in the very first session we spoke about what total pain assessment is. And when we were looking at total pain, we were referring to physical pain, emotional pain, psychological, social, cultural, and spiritual pain. Then in our last session, we looked at comprehensive pain assessment. We said that pain is what the experiencing person says it is, and it exists wherever he or she says it does. We also looked at why we should conduct comprehensive assessment. One of the reasons was that it is the 5th vital sign, and that pain can be alleviated, which means that our clients can be able to live free from pain. Then we looked at a few barriers to pain assessment. For healthcare professionals, we find that the barriers are the perceived lack of time to conduct and document total pain assessment and also reassessment. And then when we came to the healthcare system, we found that the barrier was the unavailability of culturally sensitive instruments for pain assessment in the healthcare setting because currently we are using universal ones. Then we looked at the barriers from the client or the patient, family, and the society side, where we find that sometimes there are cultural and spiritual beliefs that could be a barrier to pain assessment. And there are also myths about pain and treatment, which also act as a barrier. We then ended our presentation by looking at the pain assessment guidelines and standards, where we were able to refer to the National Palliative Care Guidelines of 2018, looking at pages 15 and 16. We had a case presentation from the Manzini Government Hospital, where they presented about a 33-year-old female client who was diagnosed with perineal cancer, which was locally advanced. The main concerns and complaints were that the client had been rejected. The client had been rejected by family and relatives and had no place to go upon discharge. Another concern was that the client was approaching end of life while still in the hospital, and the patient was anemic and had no one to donate blood for her because her relatives wanted nothing to do with her. So the plan from the Manzini government hospital team was that they were going to address the spiritual, emotional, social, and cultural issues that they were able to identify with the client. And they were going to continue with pain control and symptom management. They also mentioned that they were going to seek alternative placement, an alternative placement home for the client, and that they were working with the Deputy Prime Minister's office in terms of locating and linking the client with her children who are in South Africa. And they say they were also going to continue with supportive counseling. There were also recommendations from the EHA team and the participants from that session, where they recommended that the Manzini Government Hospital should consider discussing a plan for what will happen with the kids when they come the site, since the client is approaching end of life. And they were also advised to check with the client if the client understands well what the treatment goals are, because there were concerns about the client being worried and concerned about active chemo being stopped. So for today's session, we are going to have a presentation about still on pain assessment, but we are going to be focusing on the multifactorial model, where Mr. Ikele will give us the presentation. Over to you, Mr. Ikele.
Good afternoon, colleagues. My name is Sabelo Ikele. I will be taking you through the pain assessment. As you just mentioned that we are going to focus on multifactorial model of pain assessment. We are continuing with pain. And you will agree with me, colleagues, that before you intervene, before you do your intervention, before you treat pain, you need to do a proper assessment, pain assessment for better results. So today we'll be looking at, we'll be unpacking what pain assessment is. So our introduction here, as you can see on the board, we'll be looking at the broad introduction, looking at a few things about pain assessment. We'll be looking for the focus to consider the multifactorial model, whereby we will look at a number of things to assess before we come up with our diagnosis. I said earlier on that before you treat, before you offer medication to the client, you need to assess. Before you decide as a healthcare worker which pain medication you are going to use or you are going to give to the client, you need to first assess the pain. Before you know whether you are going to give weak opioids, strong opioid or analgesic, you need to assess the pain. So assessment here, pain assessment here is of paramount importance. Then we will look also physiological and sensory factors, which is the common tool that we use as healthcare workers, PQL, RST. This is the tool, our pain tool that we use for the pain assessment. Then We will look for physical pain assessment and the summary. So as our introduction, we will be looking at, as we can see, that it is a multidimensional observational assessment of a patient's experience of pain. It is a broad concept involving clinical judgment based on observation of the type, significance, and contents of the individual's pain assessment. We will see that the assessment here is based on the client's experience, the patient's experience. The pain here is subjective, and two clients may report pain severity differently from each other. So it is subjective. We hear from the patient what the patient feels, what the patient experiences the pain. So to successfully relieve pain and suffering, accurate, continuous pain assessment and reassessment are critical. So it is very important as healthcare workers to document, because this comes after documentation from the initial assessment up to the last assessment. We need to do a proper assessment for a better diagnosis and a better intervention for our clients. Then the last one is it involves 6 factors that need to be considered during the pain assessment. That is the multi-factorial model that we are going to use as we are continuing with our session. So here is the multi-factorial model of pain assessment. We will looking at the 6 models here. It is physiological, it is affective, what the patient feels, the moods, and cognitive, behavioral, social, cultural, and environmental. So as we can see that after the affective here is how does the patient's emotional states affect his or her report of pain. We said earlier on that pain is your assessment is based on the client's subjective. It is subjective, something that you hear from our clients. It is what the patient feels. How does the pain influence the patient, the patient's affect or mood? Yeah, we assess the patient in terms of depression, in terms of anger, distress, anxiety, mood disturbances, and loss of control. So this is how these are the things that that influence or that affect pain in the client. So the cognitive part here is how the patient's knowledge, attitudes, and beliefs affect their experiences. What is the meaning of the pain to the patient? You assess that. How does the patient's experience with pain influence the pain? We are looking at the patient's perception to pain. How does the patient feels? What does the patient knows about the pain that he or she is experiencing? And in behavioral is how do you know the patient is in pain? You look at the expression. How do you know? It comes to a point whereby it's subjective and it's objective. Subjective, yes, it's what the patient feels and what you see as a care worker. You see the mood, you see the expression. How does the patient feels, or how does the patient cope with the pain, the actions? There are a lot of things that the patients do. Some people cry to express that they are feeling pain. Some people groan. Some people show by facial expressions, some show by lying down to relieve the pain. There are a lot of things that the patient do in order to express what they are feeling in terms of pain. The social cultural one part is that how does the patient's social cultural background affect the pain experience, expression and coping? What does the patient do? How does he understand about the pain that particular person or that particular patient is feeling? The environmental part here is how does the patient's environment affect the pain experience or expression? This is whereby the patient perceive pain in different ways. It depends whether it depends the place where the patient are. Some patients may feel less pain when they are at home, while some patients may feel less pain when they're in the hospital or whether they are anywhere. So the perception of pain here differs, it varies. So the environment in which the person receives pain management, it's creating environment. So as care workers, we have to create environment. As we assess, as we do our pain assessment, we have to create an environment free from bright lights because some are very, very allergic to that. Extreme noise, in some cases, louder noise or cooler environment may aggravate pain. So us as healthcare workers, we need to look on that, how to relieve that, because we are trying by all means as healthcare workers to relieve that pain. So in physiological or sensory, we look at, because I mentioned earlier on that this is the common tool that we are using as healthcare workers to assess pain in physiological or sensory factors. So this is what is causing the pain, patient's pain. How does the patient describe his or her pain? Because you mentioned earlier on that our assessment is based on what the people, on what the client is saying. What does the client feel inside in terms of pain? So when we look about the physiological and sensory factors, we are looking at the PQRST, which is the model that we are using to assess pain for our pain assessment. So the first part is the precipitation and relief factors. This is whereby what factors precipitated or aggravated the discomfort, what causes the pain to be higher, what causes the pain, what alleviates the pain, what increases the pain, what makes the pain worse, what makes the pain better, or what does the patient do in order to relieve pain? What are the things? It may be environmental factors. It may be something that makes the pain worse or better. This will help the healthcare workers to decide on which part of intervention they will use. Are they going to use the pharmacological intervention, or they're going to use the non-pharmacological intervention? So it comes back to our pain assessment here. So the Q part is whereby the quality of pain. We look at the quality of pain. We have to ask the patient to describe the pain or discomfort and its characteristics. So the patient owns words or qualifiers. You have to ask the patient, how does the pain, what is the quality of pain? Some will mention aching, some will say the pain is throbbing, some they will experience sharp pain or stabbing or sore penetration. So it's something that you hear from the client. So it's something that you do in order to dig more, so that you can come up with an effective diagnosis and intervention. So also we look at radiation because the pain radiates from one area to another. The patient may feel one or more types of pain. You ask the patient, where is the pain? The area where the area involved here, where does the pain radiate? Does it radiate? Does the pain move from the toe to the hip? Does the pain move from the shoulder back down along the backbone, or the patient will tell you because it's subjective. Where does the pain? Are there any other symptoms of the pain? What are other symptoms like fever that are accompanying the pain? The severity. How does the pain? Here we normally use the scale, the pain score. You let the person describe how the pain is. Does it the pain score ranges from mild, moderate, or severe? How does the pain? Is it mild? Is it severe? Is it moderate? Because there are suitable drugs here, suitable medication for each and every quality of pain, for each and every pain whereby it is the severity. There are suitable medication for that. So for us as healthcare workers to assess that, we need to come up with a better diagnosis. And the time also, we check how long has the pain had, how long has the patient had the pain. Some pain are chronic, some pain they are acute pain, they are chronic pain. So when we look at the time frame here and the treatment used to control the pain, we look at that. We also look at the intermittent and constant one. How does the pain looks like? Is it intermittent or is it constant? How does the pain, the person feel about it? So you look at these things, we assess all these things. By assessing all these things, and you assess and you reassess. Also, you document for the next person to do the continuum of care, to do a proper follow-up to the client. So we do the necessary assessment there. So without this assessment, without this proper assessment, so the patient's care will not be as good as the patient may need or as the patient may deserve. So our physical pain assessment here, we are going to look at we take the history of each pain. As I have mentioned before, you look at all the factors that contribute in pain of the person or of the patient we are treating. We conduct a physical exam. There are things that you will not as you do your physical examination to the client. As you take the history, the medication that the person or the patient is using, how does the pain, how many times does the patient feel that pain? You find it from your history taking, and you find it from your physical examination. Some of the things like the person or the patient cannot say or cannot report to you as a clinical worker, but as you do this, as you conduct this physical examination, there are still things that you will pick up from that. Then you determine the cause of pain. As a healthcare worker, you map out the patient's pains on the body chart. You diagnose the pain as either nociceptive or neuropathic. If you have done the proper pain assessment, you will come up with these things. Then at the end of the day, you document all the findings that document the findings and management in the patient's file. So you do all these things. So without that, diagnosis will not favor, or the person or the patient will not get what you as healthcare worker is supposed to give that person. So in our summary, the evaluation of pain is one of the foundation pillars in the outcome of assessment. A thorough assessment of the previous pain history may contribute important information to the pharmacological correlate causing pain and may be of substantial prognosis importance. So you need to do a thorough assessment. At the beginning of this session, in our introduction here, we said we do the assessment and we reassess. We assess and we reassess. So the previous assessment will give an aid to the reassessment. So for continuum of care, we need to do that. Then the healthcare worker should be aware of the influence of coping strategies, such as pain acceptance, pain tolerance, and other things when you evaluate the pain situation of the patient. So the healthcare worker here should think out of the box and see the other factors that can contribute to the pain perception from our clients. So a proper pain assessment is very, very important as a worker, so that the patient, our patient, also for our patients to get proper help, proper health care. Our healthcare system will do a great job for when we ask healthcare workers if we can do a proper pain assessment. So that was my presentation for today's session about pain assessment. Thank you very much, colleagues. Thank you so much. Please.
Thank you, Mr. Kele, for the very clear and enlightening presentation. I hope it was audible enough to everyone, colleagues. If there's any questions or any comments that you'd like to make from the presentation, you can raise your hand or you can write in the chat box. But what I really got from this presentation mostly is that the multifactorial model is comprehensive because it holistically addresses all the aspects or all the factors that could cause pain or that could influence how pain can be treated or how pain can be alleviated. But as mentioned in the presentation, assessment and reassessment is very key, as well as documentation. And coming to the PQRST, I feel like it's a guide that, or it guides us on what elements or factors can cause pain and what the proper treatment can be, because if you've done this assessment very well, you will know that from the assessment, the client needs this kind of medication, because we understand that there's different kinds of medications available for different types of pain. And it was also interesting to learn that there are environmental factors that can worsen or alleviate a client's experiencing pain. And that when looking at the cognitive factor, there are beliefs, knowledge, and attitudes that the client has that could affect how they actually experience and express pain. I don't know if there's anyone that wants to add on the presentation or has a question with regards to the multifactorial model that has just been presented. If you have any question or comment, kindly unmute yourself or write in the chat box. I will take this as a sign that we were all able to understand the presentation. But if you feel like we are leaving you behind and there's something that you wanted to say, please indicate in the chat box. We will be able to read it out to everyone and have a discussion about it. But in the interest of time, I would like to give this opportunity to the Mbabane Government Hospital, Sister Felicity Kele, to give us a case presentation for today.
Hello, afternoon, team. Am I audible that side?
Yes, you are.
Hey, yeah, my location today is just fighting with me. Afternoon, team. Just to add one point on the environment for the previous presentation, I think also we have to look is the issue of social media. Now our life, people are living in the issue of being connected to social media. Sometimes that can cause pain, sometimes that might relieve pain. But we all have to do the same thing. You assess and check with the person. If social media, she likes to hear sad stories, I advise her to reduce those connections. If it's sad, my presentation. Today I don't have a computer. There is no connection in my place where I usually have a computer. Presentation date here is 5th of October. I'm now starting my presentation. My name is Felicity Lukele. The type of the patient, it was a follow-up, a 40-year-old female with diagnosis of metastatic cervical cancer. What is the main problem or common that you have about this patient? The main problem is the patient is passing scanty blood urine through Foley catheter. My concern is that there is a high possibility of reoccurrence or metastasis of the cervical cancer and renal failure. Now with the renal failure, this patient had completed chemotherapy and radiation treatment in 2021. Holistic assessment. The chief complaint of the patient was the oliguria, accompanied by lower abdominal pains. Duration is 3 months. The assessment, clinically stable patient, fully awake and well-oriented with a Foley catheter collecting blood scanty urine in the tube. It was not even reaching the back, it was just only there in the tube. So mainly, as according to the presentation, I just concentrated on the qualitative pain assessment. For the PQRST type of assessment, our government developed a pain assessment tool composed of this table below, whereby you have to ask information according to this. But these questions, they end up going back to the PQRST the presenter has spoken about. So the patient had two types of pains. There was pain 1 and pain 2. The pain 1 is the one which is localized lower abdominal pain, and then the other pain, type 2 pain, is the pain she experiences on the anal area. Okay. Duration of the pain 1 is 3 months. Character or description, it is dull. It's a dull pain. Pain rating, Here we were using the 0 to 5, and the score is 3. Periodicity, it's either constant or intermittent. The patient said it's intermittent. Respiratory factors, she said it's the chemo treatment. Relieving factors, it was only through medication. Then does the pain affect her sleep? She said yes. Does the pain affect mobility, moving around? Yes, it did. Effect of the current medication, there is none, partial or complete control, and her response was partial. With a type 2 pain, the duration was only 2 months. Oh, character or description, sorry, it was a typo of 2 months, no. She said it was an undescriptive, and then I assume it must be a dull pain, because sometimes, when they use the vocab, translating the vocab to Swahili is the problem. So that's that, but the 2 months is a typo. Pain rating, she said it was lower than the other one, so the score was 2. Periodicity, it just comes and go, intermittent. Precipitating factors, it was passing off stool, to only when she wants to pass the stool. Relieving factors, it was by applying a stool softener. Was the pain affecting her sleep? She said no. Does the pain affect mobility? She said no, I will just walk with that pain. The effect of the current medication, she said it was partial. So it was not really relieving. Then also with the pain assessment tool, according to the government, that was designed to use, there's a pain evaluation form. The presenter stated that we should evaluate the pain, okay? So the rates is, on the intensity of the pain, there is none. You write N. When it is mild, you write M. When it's moderate, you write MO. When it's severe, you write S. When it's overwhelming, you write OW. So according to the dates, as we know that you have to assess, review the patient. We started assessing the patient on the 27th of October, and our last assessment was on the 3rd of October. So with the first assessment date, the location of the pain was on the lower abdomen with a pain score of 3/5. Intensity was moderate, duration was 3 months, possible cause was chemo treatment. And treatment given was then the morphine solution, 5 milligrams, okay, 4 hourly, although it's not there. Then on the same day, when assessed for the pain 2, in the annual area, the pain score was 2/5, intensity was moderate, duration was 2 months, possible cause, passing of stools, and the treatment was given was the bisacodyl PO 5 milligrams BD. Since we didn't have we want to apply perectal, we give the PO. Then on the review, reassessment, on the 3rd of October 2022, the location of the lower abdominal pain, it was reduced. It was now 2 to 3/5. Because she had said, sometimes just comes, but no, now it's fine. So the rating was now mild to moderate, because she was, sometimes then otherwise, just like that. Then you have to write the the mild to moderate. Now the duration still is the 5 days. Possible cause, she said it's non-specific. I think it's because she had stopped even the chemo. Treatment now being taken was paracetamol, 1 gram PO TDS. the patient stopped the morphine after 48 hours on commencing the morphine. She just she said, okay, she had some other issues, then she stopped. It was and the pain was controlled. On the 3rd of October, for pain 2, which was in the anal area, the pain score remained at 2/5. Intensity was mild. Duration was 5 days. Possible cause was still the passing of the stool. As treatment was still the 5 milligrams PO BD. And then on the progress following intervention. Actually, our holistic tool, we have some places where we even shade. There's a picture of a person standing. When the patient say at lower level, you have to then shade there and the lower level of the person. When it's in the anal, you have to stay there. When you're staying in the shoulder, you shade the area in the picture. And also for the qualitative pain assessment, there's also a graphing whereby on the day you start assessing the patient, you put a dot and join a dot in the second day time as it goes by. So then you join the dots to make a graph to see if the pain is going up or is being treated, it's going down. Unfortunately, I couldn't put it, the soft copy here in the presentation. Then we have a pharmacological management and a non-pharmacological management of the pain. And then on the progress following intervention for this patient, urgent hemodialysis and referred to urologist. Meanwhile, transfused with whole 3 units of blood. Patient had 2 sessions of dialysis and urine output still poor. However, signs of pallor were reduced after transfusing 2 units of whole blood. Pain is now reduced to mild and stroke moderate and is being controlled very well with the paracetamol 1 gram PO, and the chemo treatment for now is withheld. Significant medical stroke surgical history. Medical history, patient is on ART, APC 3TC, DTG, when it was initiated in 2009 in that regime that was present in that by then. She was diagnosed with cervical cancer in 2020 and then started chemo and radiotherapy in February 2021 in South African hospital. Treatment was effective with remission of cancer. So the signs of cancer that the treatment, they just reduced or patient was cleared of cancer. Surgical history, no operation performed. Medication, relevant past medication, I wrote the ceftriaxone 1 gram IV for BD for 5 days. Then omeprazole 10 milligrams IV OD for 7 days. Oral morphine 5 milligrams 4 hourly for 5 days. The Rosefen because there was highly infection. Then omeprazole because the patient was complaining of epigastric pain. But now the patient is on Lasix 40 milligrams IV BD for 7 days to challenge the kidneys. And also metoclopramide 10 milligrams IV PRN for 5 days because she's having this uremic acid in the blood since there's a renal failure. So they're giving the anti-vomiting medication. And then the paracetamol for the pain, for the mild to moderate pain. Social history and pertinent family history. Work status, she is self-employed. Education, she ended in high school. Occupation, she's a hairdresser. Socio-economic status in the middle and poor, I would say. Marital status, she is single. Then lifestyle habits, she said she's an animal to the social media. She likes chatting. But then the relevant health condition in close family members, her mother is hypertensive but still alive and still alive. Grandmother had CVA and she passed on. Advanced directives, advanced care planning directives, they know, and there's no will. Healthcare proxy, there is no. She doesn't have, she just decided on her own. Mental capacity, yes, it was assessed. Comments and consent, please, more comments or consents. The patient strongly emphasized that she was told to be cancer-free after completing treatment and will not resurface. She is not ready to fight the battle of illness again. Review of systems. The vital signs, the temperature was normal, 36.5 degrees Celsius, BP was 11/96, pulse was 109 beats per minute, respiration rates were 24, her saturation was 96%. Pain score. Okay, here when I rate it from with the over 10 scale, it's 5/10. There's an interruption. ECOG functionality score, the one which is her was rated to be 2. She's in bed, yeah, and chair, because she just walked less than 50% of time. Yeah. So with the assessment of these symptoms, pain, the score is 4. It's 4 to 5, something like that, because it's not yet severe. Dyspnea, there's no dyspnea. Anxiety, the score is 2. Agitation, score is 1. Depression, I must say it's 1. Just that it's not yet strong. Drowsiness and fatigue, score is 2. Nausea and vomiting, score is 3 because of the urine. Anorexia, she said, it's overwhelming. The score is 4. Constipation, the score is 3. Focused investigation, the FBC, the white blood cells were elevated. With the range of 14.90, the normal one should be 3.6 to 9.6. With the creatinine, also it was high. The result was 1,196, and the normal range is just 53 to 97, highly indicative of renal failure. And urea too was high. The result was 33.6. The normal is just 2.5 and 9.3. With the imaging investigations, she did the abdominal ultrasound, and whereby, okay, the comments, they started with the query, although it's highly suggestive of bilateral hydronephrosis with thickened bladder, fluid noted in the endometrium. Further plan for this patient, as she's still in the ward, we have to help educate the patient and family about reoccurrence of cancer, metastasis, and possible procedures to be performed to sustain life. For example, the stent, of which it's highly possible that should be done, the suprapubic catheter, a colostomy since and hemodialysis and peritoneal dialysis and diet, so etc. With the MDT team, oncology team, we have to see the patient, do the combined rounds and discuss for possible and beneficial treatment intervention. Then with the psychologist, we have to do the continual counseling for the patient and the family. And also the palliative care team, we have to review patients and render services as per patient's needs, counseling, network with the MDT. Then for the linking of the patient said he's not ready and to be linked with any organization or hospice because she's not ready to be connected with the hospice because when she just also said hospice services like now walking to your death. Then the spiritual care will strengthen it, will help her to strengthen her faith and spiritual upliftment. Then the family conference will be conducted so that they once again give support to the patient. Now she has to, because now she might be living with the life-sustaining procedures and have to help her now financially, emotionally, and the child care because she said she had 2 children and she was just doing the work as a self-employed person. That's the end of the presentation. Thank you.
Thank you, Sister Felicity, for the lively and clear presentation. I believe everyone was able to follow through and understand the case very well. If there's any questions that we have, colleagues, may we kindly indicate by unmuting or using the chat box or the raise of hand and actually ask questions or give recommendations or suggestions on how the client or how we can advise the Mbabane government palliative care team on managing the client. So if we have any questions or suggestions, kindly unmute and ask.
Maybe I would love to ask a question for Sister. Thank you so much, Sister, for such a case. I saw that under the problem, it is still not known that what could be the issue that has resulted to the renal failure after the patient has completed the chemo and radiation last year. Is there any definitive diagnosis available to confirm that it is due to cancer recurrence or metastasis? Because one of the things that is confusing maybe the patient too is that there's nothing maybe that has been presented as evidence of the current diagnosis. Is there anything that has been done to confirm the metastasis?
According to the investigations I found in the patient's charts, there are, I wouldn't say there's now done a biopsy again to confirm because it was not in the chart, but they look at the clinical presentation because the patient had gone for chemotherapy, then reported the difficulty in passing the urine and the nose and vomiting and was anemic. Then they wanted to check the HB. But with the confirmation from the abdominal scan, because it showed that the urosepsis, the accumulation of the fluid, and the hardening, the thickening of the bladder. So those are the symptoms of cancer building when it's thick, when it's hardening. So I think they assumed from that. And then it is true that some of the art treatment also contribute to the renal problems, but the thickening of the bladder is high susceptibility of reoccurrence of cancer.
Thank you, sister.
Yes.
Thank you, sister. Does
It-
anyone else?
The problem comes is that even when they are going through the radiation and chemotherapy, usually they do explain to them that it might reoccur. Just that then they take like now it will not have that fate. And yeah, that's her worry. So we have to now walk again and explain to her and prepare her, because she was just looking fine and healthy. She was just kept on saying, I cannot fight this disease again. It costed me a lot.
Thank you, sister, for that clarity. Still on the issue of the client saying that she cannot fight this disease again, is that the reason why you haven't been able to attend to the issue of proxy decision maker or the living will?
The issue that she's not ready to be linked. She had thought, or she had convinced herself that she has fought the Berkeley and now I'm well, I'm okay. You see? And most of the palliative patients, some who are healthy, walking around, they don't like to be linked. What I've seen, most of them, when I say palliative care, I'm still working, I'm okay. No, I don't want that. They just say, so that's why when I say, you better be linked, sometimes, this is my path, roadway to death, yet it's not.
Okay. The question was more on the proxy decision maker and the living will. Are you having a challenge discussing it with her because she feels like she's not in a state to go through the same process again?
Oh, okay. Yeah, I think we need to involve one of the closest family person, because when I was there, she said, oh, I have my cousin always keep visiting to me. Before having discussing about the proxy, they will also need an explanation about the whole situation, then go gradually to proxy, because as she is, it's highly possible that now she'll deteriorate as it advances, the disease is advancing, because at any time it might go to the lungs. She'll be having a difficulty in breathing and her life mobility would be highly affected.
Okay, sister, thank you.
Then about the will, people still associate that, it will is being done by someone who got a lot of properties. You see?
Okay.
And who is a lawyer? Where is a lawyer?
Okay, sister. Does anyone have questions or recommendations?
Thank you, sister, for sharing such a patient. It's a very interesting case. It's unfortunate that she is a mother of two, and she's age 40. At that age, developmentally, you can tell that the children are young, and she's still looking forward towards life. After then she finished the chemo last year. I don't know when they were telling her that now she is cancer free. I don't know if they told her of the probability of the parents. Now that the fact that now she's developing such symptoms makes the patient to develop this anger and disbelief. I think she's still trying to be strong for her kids. I don't know what the kids have gone through. I think having some time with the patient without discussing the prognosis, just to understand where she's coming from and how she is here, I think can assist for the patient to unpack this wounded soul that is inside. Because the fact that she is saying I'm free, it might mean the patient's understanding concerning cancer and treatment still needs to be explored. And the issue of advanced care planning needs to be discussed with the patient. That advanced care planning is for what? I'm just that scared that we might not share the truth with the patient at this point until it is too late. The fact that now she's still ambulatorial, but with the metastatic issue, we don't know what might, and we don't know what the kids will do when they see their mother now up and down the hospital for dialysis and stuff. We don't know, and we don't know the potential of this patient to adhere to any treatment any further because of the plan. I've heard that she will be put on life-sustaining therapies so that she can continue. I think even the probability of her not succumbing to the cancer need to be discussed so that she is on the same page with the team when the decision to engage in the life-sustaining therapy is made. Because it might be possible that somebody carelessly shared the issue of the good news of post-treatment recovery, but now the bad news has to be broken again. So I think even when they are broken again, somebody needs to be very careful and be cautious of how the patient will behave. So I would say, thank you so much to initiate that. Though you have never mentioned what actually is the spiritual part of the patient, to me, I'm seeing somebody who has lost hope and who is full of anger on what is ahead of her. I don't know if she understands now the status where she is and what exactly she is looking forward to. The issue also, I think the team has to also help in the issue of exploring the patient's hope for future and exploring the patient's fears, because she must be doing all what she's doing now because she's scared of something. But until we explore it, we're not able to support the patient at this time. So I think the future has to be explored. What are the fears of the patient concerning the future? Because if she's saying, I've worked so hard to fight this, then what are the fears she has concerning the future? Then I think from there, when she is able to tell those, narrate such issues, we will get to know how best we can support the patient. And the issue of death, you will find that at the end of the day, the greatest enemy she's scared of now is death. But then we can explore that through exploring the future of the patient, finding out what is she hoping for when she looks at the future, and what are the fears she has for the future. Unfortunately, she is a mother without a husband, but I guess with a father, or if the father died, I don't know. Where is the father of the two? And I'm happy to hear that she has a cousin who is supporting, But we don't know how far the cousin is closer to the, you will find that she's scared of going to death because she feels that her children will be left with no one to take care of. So, but until we explore the fears, I think it will help us to know how best we can then support the patient. And the issue of the pain control and spirituality, I think it will help us if we can invest on that issues, just to have the patient to talk, have time to share, especially preparing for the future, because once it's advanced, we know it may not come back at any point in time. And then if the children can then be engaged with her permission though, and then it can help. I think one of the things that we need to see based on today's session is that qualitative pain assessment is very important. The issue of PQRST is not just a formula to follow. It's when we assess this pain, we consider a lot of factors. We also look at how best we can support the patient and how best we can improve the patient's life. So that's what I can share for today. And thank you so much, sis. I think your team, because the patient has a right to refuse home-based support. But then I think when you're in a facility, you can still organize those sessions to deal with the future in terms of discussing what are the fears, how best we can help to deal with those fears. I think then with time, she will come into peace with the reality of what might happen based on what is happening now.
Thank you, Mr. Mahlangu, for those recommendations. I think we have come to the end of today's session. Thank you so much, colleagues, for joining us. Kindly join us again for our next session. And please invite others to join these sessions with us as well. There's a link that has been shared in the chat box. So please click on that link and give your feedback. I think we've come to the end of today's session. Have a good day, colleagues. Enjoy the rest of the day. Thank you.
Thank you, colleagues. Next week we'll be doing quantitative assessment of pain, looking at how the tools works. The next session, we hope then we are going for management.
Thank you, everyone. Thank you, Mr. Sandley. Can we close?
Yes, we can close the session. Thank you. Bye-bye, everyone.
Bye-bye. See you.